Good afternoon, and thank you for joining this NICE webinar, which is brought to you as part of the build-up to the NICE annual conference in Birmingham, taking place on the 13th and 14th of May next year. The subject for our conversation this afternoon is integration. You can't have been anywhere in the health and social care system for the last 24 months or so and not heard integration touted as the cure-all for all the ills of the health and social care system. This afternoon we want to explore what the truth is behind that. We want to examine how the 211 recently formed CCGs can work with their partner local authorities through the health and wellbeing boards to deliver integrated services at a local level. In June, the government announced the creation of a £3.8 billion Integration Transformation Fund, which will be a shared pooled budget across health and social care. We want to understand how that's developing at a local level and what progress has been made in plans for using that budget. Earlier this month, the government announced the creation of 14 pioneers who are going to blaze the trail in terms of using the Integration Transformation Fund. We're really fortunate this afternoon to have representatives from two of those pioneers joining us. At the beginning of April, NICE's role was expanded so that it's now responsible for the production of guidance, advice and standards for social care. This puts NICE in a unique position to provide evidence-based advice to the health and social care system around the most effective ways of breaking down barriers between the systems. One of the key characteristics of integrated services is that they're person-centred. We want to explore this afternoon what the potential is for involving patients, people who use services and their carers in the design and development of integrated solutions. And all of this is taking place in the context of a really cash-strapped system. Local authorities are under significant financial pressures. Only this morning, the Audit Commission produced a report which said that it was very likely that the cuts are likely to have real impact in social care in the very near future. The NHS is facing unprecedented rises in demand for its services, and competition legislation appears to be preventing a barrier to integration at a local level rather than an enabler. Only last weekend we heard that the number of beds occupied by people who are clinically fit for discharge yet are waiting for social care to be provided was running at a 3-year high. So it's a tough agenda, but we've been able to put together a panel of real experts who are going to work with us this afternoon to explore these issues. So I'm joined on my far left by John Nawrocki. John's been Director of Adults and Older People Services and before that the Director of Social Services for Adults and Children for Greenwich Council since 2004. John's work in local governments covered all aspects of children's, adults and older people's social services. And Greenwich is one of the two integration pioneers which is joining with us today. Alex Fox is Chief Executive of Shared Lives Plus, which is the UK network for small community services. It represents Shared Lives carers and schemes, social care micro-enterprises and home share schemes. Professor Gillian Leng is the Deputy Chief Executive of the National Institute for Health and Care Excellence, and she's NICE's Director for Health and Social Care. Health and Social Care at NICE covers responsibility for the NICE Quality Standards Programme, the Accreditation Programme, public involvement and NICE's implementation activities. Dr Robert Stewart is a practising GP in a rural practice, which is recognised for its innovative working and high-quality care. Robert's Clinical Design Director at Whitegate Design and is working with Kent County Council, which is the second of the pioneers represented here today, to facilitate sustainable NHS and social care, bringing clinical leadership both internally and externally through the Kent Health and Wellbeing Board. I'm Steve Sparks, I'm the Associate Director for the NICE Field Team. Now, the great thing about these webinars is it gives us a real opportunity to involve you watching back at your home or in your office to become involved in the process. And you can do that through 3 ways. If you look at the interface on the screen in front of you, you see in the top left-hand corner there's a tab which you can use to ask a question. If you type your question in, it will come through to the studio and we'll be selecting some to use during the webinar. You can also follow the debate on Twitter using the hashtag NICEWebinar. And again, questions coming in through Twitter will be used as part of the webinar. And finally, we're going to launch a series of online polls during the conversation. And I want to start now with the very first poll, which is about how far advanced local health and social care economies are in planning to use the Integrated Transformation Fund. So we've got 7 options for you. They've yet to consider how you'll use the fund. But you've started discussions in your local health and social care community, that you've developed a plan, Maybe the Health and Wellbeing Board have approved and signed off those plans. And you could be to the extent that you've already been to public consultation with that plan. Or maybe you don't really know what's happening in relation to the Integration Transformation Fund in your locality. So please get voting now. We'll stop that poll in a few minutes and look at the results. But in the meantime, I'd like to turn to the panel. We've already used the word integration a lot. I'd be interested to know what it means to each of you. John, would you like to kick off?
Oh, gosh, going back to the 1980s with community mental health teams, community learning disability teams, I've always felt the only kind of integration that really counts is the integration around the patient, the service user, the integration of the care pathway, minimising the number of handoffs between professionals. So I think for me integration is about the patient's experience, not symbolic or transitional organisational integration. And I think there are some real lessons where integration of organisations hasn't delivered the desired outcomes. For me, it's the words that you used earlier, the patient-centred experience.
Alex, would you like to follow?
Yeah, I'd like to agree with all of that. And I think also there are some ways in which thinking about integration is starting to be pushed a little bit further as well. So I think the challenge isn't just about how we integrate different services, it's also about how we integrate between services and all the forms of support that people have which have nothing to do with services and which can actually be much greater determinants of health and well-being. So I think that the new generation of truly integrated approaches will be services and professionals and approaches which have the humility really to arrange themselves around the person and around their networks, their family and their community life.
Thank you very much. Jill?
Thanks, Steve. And at its simplest sense, integration is about joining things up, isn't it? Joining up care, joining up services that make sense, as has already been said, for the patient. That's core. And so we really do need to think hard about how we do that in a system where now lots of people need lots of elements of health and social care at the same time. So it becomes quite a complex picture. Having patients and service users at the centre of that is key. The NICE, it similarly means joining things up, and I'm quite passionate about ensuring for the future we don't have separate pieces of guidance that might relate to the health system for one long-term condition. With that same long-term condition having a different face for social care, we need, as we develop our guidance, to think right across the piece with the patient service user in mind all the time.
Thank you very much. And Robert, for you?
Well, for me, integration is very much about how we build services around the citizen. And I use the word citizen because at the moment, the way that people, as they get older, actually the systems make them against having active ageing, active healthy ageing, because the services don't necessarily promote them to be independent. So we have a very medically orientated model of care. And as people progress down that, we need to really move to understand that there's much greater care than just medical and social care. There's the voluntary sector, there's the self-care element of this, and there's a lot of other elements of care that are really important. So for me, from a service provision, it's about coordinated care around the individual themselves, the citizen. And how do we join all that up? How do we make sure that we're using the new technology revolution that's out there that we don't have at the moment to share that information and to make the person feel that they are supported in their own self-care, not necessarily left to swim in the sea that they're not able to do. So for me, that's one part of integration. The other part, which hasn't been mentioned, and I was in danger of agreeing with everybody on the panel, was that it's about how we get all of the planning together and make sure that the people who are responsible for some of the decision-making look at this from a total integrated point of view, bringing in public health, bringing in housing, bringing in the CCGs and social care, so that we actually have a coherent vision of what sort of services we'd like our individual citizen to be able to expect.
That point about the wider perspective of provision of services, things like housing, the wider determinants of health, I think, is a really valid one. Is there an opportunity when looking at integration to actually spread our net a little further, to look at interventions from different parts of the system than traditionally we have done, to try and improve people's chances and opportunities? John?
I think the more universal the service offer, the better the option of integration. So the public health agenda for older people is identical to the prevention agenda for older people. And 95% of our service users, particularly the over 85s, have got a related health condition, whether it's a long-term condition or an acute condition. So I think public health and local government's a huge opportunity, touching on housing, transport, leisure services in the way that Robert mentioned. So I think the changes that follow the Health and Social Care Act open some doors. They do close some other doors because, you know, you create integrated services, you create new boundaries with other parts of the organisation. So there are challenges as well as opportunities. But I do think that the universal offer is the one that we can really latch into.
Alex?
I'd agree with those points about prevention and public health in particular. I think we have a tendency to talk about prevention from a service perspective. You know, can we prevent people from needing to use services? And actually, when you start to link it into thoughts about public health and well-being, you start to think about issues like isolation, which services can't really touch, but which are hugely important to the person's well-being. And actually, if we're successful in helping people tackle those issues, they will often need less in terms of formal services. But those kinds of interventions that are needed to tackle issues like isolation look very different. They look integrated because they look as if they're arranged around the person, but they might actually be as much about what the person is helped to do themselves and what they're helped to do with those around them as what a service does.
And only this week we saw a really good example of that in terms of NHS England's call for people to become Samaritans to elderly neighbours over the winter. A really good identification of an informal response to that sort of need. Jill, was there something you wanted?
It just resonated when you mentioned housing, because I've been speaking at a number of conferences over the last year about our new social care programme, and every time there are a number of questions about the importance of housing. At the moment, that's not something that is on NICE's agenda, but there's obviously a demand for housing, public health, all the other elements that actually impact on our healthcare and social care to be aligned, and so I'm certainly keen that NICE should contribute as much as possible.
Great. Well, as part of the preparations for the webinar, people have sent in questions which they wanted us to use during the discussion. And we had one from Caroline Allnut, who's working around supporting local transformation in North West London NHS Trust. And Caroline was interested to know how we create a genuine shared agenda between health and social care organisations, rather than just a converging of respective objectives. And I think that's very much getting at what you were hinting at right at the outset, John. In the past, often we've brought organisations before, but we've not done something really transformational. Do any of you have any thoughts about what we might be able to do differently this time?
I think it's about areas of common interest, really, because we all have core business. There is core social care business, which involves social services professionals. There's core NHS business. I think we need to identify the overlaps, think about the Venn diagram. What's the shared interest? Then what are the health, public health, social care outcomes that define that shared interest? And then how does the organisation mould itself around that shared interest? So I think it's about working backwards from the desired outcome rather than seeing what bits of the organisations might work together in a certain space. So define the outcome rather than define the process at the end of the day.
That's a really good perspective.
Well, I'd like to say that the important thing about this integration is that there's no point it just being services joined together, because that means that we've just got a bit more efficient use of the present system. Actually, we need to change the way that services are working together, because the actual needs of the individual has changed than the way it used to be. Whereas before it was very much the GP being the person who did the signposting or the gatekeeping, as people used to say. But this isn't about preventing people from having supported care. This is about the opposite. This is about trying to find ways that actually people would feel supported in their own home and actually start to feel that the default place of this, the default place of safety, is actually in their own home, not in an A&E and not in a hospital ward, which we know is the place that they're least likely to get to. So from my point of view, it's very much around transformation of services and how we bring in the wider people who are able to help with that. People like the voluntary sector, as I said earlier, or Age UK. And if you ask them what they're doing, their integration of services is quite different looking than what health or social care would say. So we should actually value that totality of services and actually start to make the citizen not just the person who's seen as the patient or the problem, they're actually part of the solution. And so that is true of all of the other organisations who provide health and social care. It's not that A&E is the problem. At the moment, it's one of the few solutions. We need to make sure that we've got the right solution for people to stay in their own home.
Alex?
I think the Care Bill shows a way in which actually this could be made something that's a little bit more mainstream in thinking, because I do think that social care has probably progressed further down the lines you're talking than healthcare has traditionally. So the Care Bill says that the purpose of social care is going to be to promote well-being, and then it defines well-being incredibly broadly. It doesn't just talk about physical and mental health, it talks about active citizenship, about family life, about employment. And it suggests that this whole public service sector should go deep into the kind of territory that services where services can't achieve outcomes on their own, which hasn't been hugely commented on beyond the social care world. But actually, I think that's potentially extremely radical. And what I'd really like to see is health, social care, housing, all aligning themselves around that idea of a public service whose role is to get alongside people and help them create their own well-being.
And just to add, to have a shared agenda, everyone has to be clear that we are all sharing the challenges and that we could all share the benefits from working together. And there are some interesting things, aren't there, that to support that, we need to be better at communicating. We need to think about sharing a joint language, for instance. People use different terms to mean same things, which doesn't help. We need to therefore have a shared culture and information. There's a whole number of things that underpin the shared agenda and the shared benefits that we'd all accrue.
So there's some real leadership opportunities there in terms of bringing the culture forward. John and Robert, you're both from two of the 14 pioneers. It would be interesting to hear a little bit about what's happening locally within Greenwich to start off with, John, around the Integration Transformation Fund and your plans for improving integration of services.
OK, Steve. It has its roots about 5 years ago in Greenwich, actually. We identified a number of parallel lines of hospital discharge process around occupational therapy, physical therapy, consultant referrals, social work assessment. And we decided that we had to bring those parallel lines together into a single process. And that's led now to a fully integrated community health and social care system around early intervention, assessment, rehabilitation and care planning. We started off with 5 teams, 3 community assessment and rehabilitation teams, an integrated hospital discharge team, and an emergency intervention team called the JET, the Joint Emergency Team. And those 5 teams were the starting point for the Pioneer application, because what we wanted to do was build that integrated system into the 5 GP syndicates, the 5 localities within Greenwich, based on around 50,000 people. And we identified that within those 50,000 people, there were probably 300 or 400 people with very complex interacting long-term conditions. So we had a model driven by the needs of the clusters of population. But essentially, it was about trying to create a totally integrated and holistic health and social care system, not just community health and adult social care, but GPs, primary care, mental health, and some of the specialist services in the care pathway. So it's been bottom-up, really, the process.
And that's really great to hear that it's got such a long pedigree behind it, but it's something which is partway to being embedded in practice already.
Yeah, staff cultural development's been crucial, and the communication that you mentioned, people speak different languages, so actually learning the different cultures has been critical. And it's sustainable, that's the critical thing. You can have step change which isn't sustainable, and that's risky.
Great. And Robert, what's happening in Kent?
Well, we've been very excited to have become an integration pioneer, and I think there's quite a lot of excitement around that. So we have actually created an integration pioneer group that's actually a working group of the Kent Health and Wellbeing Board. So that's really exciting. It allows us to look at some of the cross-cutting issues. It allows us to do some of the barrier busting. It allows us to try and move to this supported self-care and trying to find ways that we can deliver the vision of the person at the centre, that the citizen at the centre is able to have the care designed around them in the more totally holistic way, not necessarily just health and social care. So one of the things that we're going through at the moment is also how we use the Integration Transformation Fund or the Integrated Care Transformation Fund. There are lots of names for this fund. The one thing that we do know is that this fund is not new money. Mm-hmm. And there's a real importance that if we just squander this money, then all we'll be doing is having a leaky bucket that leaks more. So this Integration Transformation Fund has got to do what it says on the tin, and that is actually to transform care. So we have got quite a good consensus across Kent about how we take that forward, and that means that we're really able to take some of these issues. And all of the difficulties for us in Kent are to some degree that we have 7 CCGs, we have 1 big local authority, and so we have some quite big providers, but we are working on this together. So we believe that we can be bold. We're looking at the whole system transformation, and we're also looking to see how we can build on the work that the CCGs are doing, so that we end up with a coherent view of what the citizen could expect. But it isn't necessarily consistent in each of our 7 CCG areas. Mm-hmm. Actually, there's got to be some local variation, partly to do with geography and need, but also partly to do with local relationships. So we're very keen to make sure that we have coherence, not consistency, and that we actually use this group to facilitate that transformation and do the issues like the barrier busting to enable the local CCGs to deliver.
And do you think you'll be able to do that at pace? We've had a question come in from Ali Wilson, who is saying the real challenge is how we achieve this quickly. It's not something which we've got 10 years to put in place. The financial pressures are such that if we don't make these solutions work soon, we're going to be in a lot of trouble.
Well, I totally agree with Ali, and I think that the issue for us, though, is you have to have some sort of vision about where you're trying to get to, so that we don't tinker around the edges. At the moment, we're in danger of thinking that just because everybody is standing around the Titanic holding hands, that means that we won't hit the iceberg. Actually, the truth is that they've got to change the way that they work so that we can do it in a different way. So our view is that we can't do this all at one go, but in Kent we want to be bold, and we want to do it whole systems, and we want to try and get to a place by 2018 that is the model of care that we're moving to. So this is radical evolution. It's not about tinkering around the edges. And in fact, the determination out of our Integration Pioneer Group was we can't look at the Integration Transformation Fund as the pot of money that's important. Actually, it's the totality of the money. And as I've said earlier, that is the totality of the resources that in Kent might come from the voluntary sector as well as community capacity, and using the citizen as a real person who isn't always the taker of everything, but actually contributes to the solution.
Jill.
And I just wanted to ask a question, if I could, because building on how would it be achieved quickly, what are your success criteria? How will you know when you've done it?
Well, that's a really good question. Thank you for that one. My view is, so we think that we need to try and devise some proper modelling that actually means that we don't, and this is quite interesting from a NICE perspective in my view, because I think there are different elements. So it's quite easy, you could say it's quite easy to sort out the finance thing just by cutting services, but actually that's not going to deliver you the clinical outcomes that you have to deliver. So we're looking at whether or not we can find some mathematical modelling that includes the clinical outcomes, the safety and quality outcomes, the citizen experience, and the financial component. And it's all of those together that need to be understood as to whether we are actually moving from red to green, or whether we're moving the other way. And from Kent's point of view, that's as relevant for each of the CCGs as it is for the totality of Kent. So if we can get there, and I'm not saying that's easy, but there are clever people out there who can analyse this data in that way, then we should be able to see in a simplistic way such that the Health and Wellbeing Board for Kent can be reassured that we aren't heading towards the iceberg anymore. We're now moving in a different direction to try and sustain health and social care and the totality of services around the citizen.
And I think you need a mix of qualitative and quantitative outcome measures as well, and triangulate the evidence that you have. So the PROMs and the CROMs, the patient-reported outcome measures, the clinician-reported outcome measures, some tangible things like reductions in the number of bed days of occupancy, the number of avoided admissions, which you can calculate by pre- and post-comparison of activity levels. You can really look at the whole system and combine soft information with tangible, measurable statistics and looking at quality, safety and effectiveness in the way that Robert's decided. It's a complex measure, but you can really do it. You don't just have to stick your finger in the wind and hope that things are going to improve.
I think it's also worth thinking about involving people, citizens locally in designing some of the measures as well, alongside some of those kind of more service-led measures that are equally important.
So it's about the patient focus at the end of the day.
The one thing that I think is really important, though, is that I'm a doctor and I like clinical evidence, but I don't think we've got time to wait for all of the evidence for this transformation. I think we have to be much more fleet of foot to go into more of an implementation research or implementation evaluation, lots of people want evidence as a reason for sometimes not doing these things, as well as, but we know that we've got to get on and do this at pace and scale. So upscaling is really important for us.
Because one of the things we have really clear evidence for is that the status quo doesn't work and will send every area bust. So I think when you set the potential for change against that status quo, actually I completely agree with you that should put the desire for evidence in perspective.
One of the words which has been used frequently so far in this conversation is citizen, which isn't one you often actually hear bandied around. And it means something quite different around not only people having rights but also responsibilities. We've had a question come in from Nicola Kingston asking how we can ensure citizen representatives involved in these conversations are empowered to become leaders in their communities. Is there something which we can do to actually skill people up to become really well engaged? Alex, I wondered if you had any thoughts around how we might be able to do that.
Yeah, and we're going to come on to the poll question in a minute. It was interesting that the way the poll question is set out, it seems as if we've been to public consultation with our plan was the last sort of stage of development. And if you were to look at models of co-production, and I'd recommend the Think Local Act personal work on co-production. You'll see that actually co-production is co-designed from the start. So it's involving people who use services and their families, and actually recognising that all citizens in the community have a stake in this. It's also about involving providers, because providers have a really important role to play in designing new approaches, working with commissioners. And I think that has to be genuinely co-produced from the start. And if we do that, we'll find we have more integrated approaches, because people don't regard their lives as I've got a health issue here and I've got a housing issue here. People think of their lives in the round and will set naturally more integrated goals than services ever will.
Brilliant. Well, you mentioned that first poll. We're now closing that, and the results are in. We asked people to indicate how well advanced their local plans were. As Alex pointed out, we've got public consultation as the final step rather than the initial step. Nobody has been to public consultation with their plan yet. The most popular response was that people really didn't know what was happening at a local level. Nearly 60% of people said that they were unaware of what plans were happening. I think that might be an indication that we're still in a fairly early stage. However, just over 27% of people said that discussions had started in their local health economy, and in just over 2% people have developed a plan. So it seems like there's still quite a long way to go in terms of progress around the development at a local level. I wonder if any of you have got any observations around those responses from the audience.
It's not surprising, really. It's not a hugely visible issue at the moment. It's very much about the NHS and local government interchange. I think one of the key things is that it's not about next year, it's about 2015-16. There is some increase in funding next year, and we've shared that with our Health and Wellbeing Board, for example, and we've agreed a profile of expenditure. But it really is a step change in 2015-16. The adult social care spend nationally is about £17 billion. The Integration and Transformation Fund is £3.8 billion. So potentially it's a 25% increase in the amount of funding available for whole system work. So I don't think it's something that I'd want to do within 2 or 3 weeks. I'd want to take some time thinking about the real engineering and transformation that can benefit from that, because it really is a step change in the funding available at the interface of health and social care.
Jill.
The public consultation should be a really crucial stage of taking this forward, shouldn't it? So it's reassuring to know that as nobody has got to that stage, people don't know. If there had been public consultations and people still didn't know, that would be the worrying thing. But I think, as we all started out saying, integration is about putting the needs of the individual at the centre. That has to be remembered as the plans get rolled out and taken forward, and that public consultation is really important. And after that, if we reran the poll, hopefully people would know what's happening.
Great. Well, I'm going to launch our second poll, which is about the biggest challenges that people face locally around integrating health and social care. And we've got 5 options now, and they should be appearing on your screen now. So is the commitment from cross-sector partners one of the areas that's a great challenge? Is it lack of consensus amongst the organisations involved? Communication and coordination? Or perhaps financial resource pressures, or a combination of all of the above. So that'll run for the next few minutes, and we'll come back and look at the answers in a moment. I'd like to go back to Robert and John. We were just talking about the development of the plans locally for health and social care integration. Where do you position yourselves along that spectrum which we were just discussing as part of the first poll?
Well, I would suggest that we've probably got some of all of them and not very good in all of them as well. So that I think that the issue, we have got commitment. We've got to recognise that some of the present situations are difficult in terms of the financial pressures on the different organisations and the different agencies. So I think the commitment is there for us to look at it. How we use the Integration Transformation Fund, I think, is a debate, and also is a debate as whose decision it is as to how it is used. So I think there's still a question as to who is really authorised to agree the plan as opposed to sign off that it's a sensible plan, which seems to me to be different. I would suggest that we've got quite a lot of consensus, and one of the things that we need to do, and we're trying to do, is communication and coordination is a really important element, which we've started to do. We're about to launch the Kent Innovation Pioneer Hub, and that's going to be a way that innovators can contribute to this discussion, and we hope that we're going to find ways of being able to engage the wider population as well as the private sector, the voluntary sector, and our academic organisations. So I think the financial and resource pressures I see as a challenge, but probably almost a wake-up call, because we all know those challenges are there. So I think that that's probably an enabler, not a challenge from my point of view.
I'd agree with that, actually. But also there are some tensions in the system. So if you listen to the story of the Integration Transformation Fund, it sounds slightly different when articulated by the NHS from the way it does when articulated by the Departments of Communities and Local Governments. There's talk of allocations rather than new funding. So I think there's still some debate to be had about what does the element of covering existing expenditure mean, for example, because one of the 7 lines of expenditure is covering for existing social care pressures. So I think there's some way in getting an agreed definition of what the ITF's about. I think we need to think of a more sophisticated way of rewarding activity in the health and social care system. So whilst ever we have a tariff system of payment by results, then commissioning in the NHS becomes about referral and care pathways. Commissioning in the local authority is about personalisation and delegation of budgets to individuals. So commissioning's changing as we speak. I think we're not quite on the same page yet in how we see the future of the fund. I think the key issue, as Robert said, is it's got to be transformational, and it's not new money, so we can't afford to waste it.
Alex?
Yeah, and I think to add to that, I was really glad you picked up on that some of those cultural differences around commissioning in the NHS and social care with individuals in control of budgets much more frequently. I think there's also an issue around the lack of a shared sense of outcomes, because I think in both of those commissioning environments there's still not the emphasis on commissioning for outcomes, and particularly not for the kind of outcomes that we've been talking about, which are generally thought of as hardest to measure. But I think it's also the case that actually we just haven't developed and disseminated the tools to measure them because they haven't been high enough on people's agendas. So if you're looking at broader outcomes around well-being, for instance, it's really hard to commission for that and to pay for it in a payment by result system, partly because it requires a lot of different interventions working together, but partly because it's really hard to get hold of a robust measuring tool to do it.
And we've been talking about tariff and the way in which reimbursement systems work differently across the systems. Do we have a feel within maybe the pioneers that there may be some flexibility around how that can be operated? Because they're determined at a national level often, aren't they? How's that going to work with the local determination of how you want to integrate services? Is that a freedom that you're going to have at a local level?
I think there are all sorts of issues that need to be addressed around that. The tariff-based system does mean that we find situations that people are rewarded for providing bad care, not just rewarding to provide good care. We also know, this is a personal view, that whilst it's really important to have clinical outcomes, and it's really important for those clinical outcomes at the beginning of people's journeys on their long-term conditions, as they end up with more and more long-term conditions and they get closer towards the end of their life, those clinical outcomes are actually negative. they can actually produce ill health as well as necessarily health. And the example of that is easy, because the medical solution to people who are getting iller is to put them into hospital. We all know that that's not the right outcome. So our system of both medical education and our system of rewarding behaviour is not necessarily the right one. I would also go on to talk about QOF in the same sort of way, the Quality Outcomes Framework, because I think it's been a great tool. I think NICE has been a great organisation in showing us how to use evidence. But when you get multiple long-term conditions and you put them together, you can't look at each of those things in isolation. And the totality of that means that we have a lot of older people on polypharmacy who are ending up having a lot of hypoglycemic attacks, lack of sugar attacks, and falling over due to low blood pressure. Because of the treatment we're giving them fractured hips. So we need to change some of those to recognise that if we go towards supported self-care, as they get towards the end of their life, or as, in fact, if we're going to talk about active, healthy ageing, it's actually quite a long time before the end of their life. They could have these long-term conditions for quite a long time. We need to have a paradigm shift in the way that we understand the evidence and the outcomes.
On that exact point, Robert, we've had a question come in from Abraham George, who's a public health consultant in Kent, and he's asked Jill, with population ageing and increasing prevalence of multi-morbidities, how will NICE support the evolution of clinical practice, moving away from pathways of care based on single diseases and looking at programme areas across multi-morbidities? Is that something which NICE has started to think about?
Indeed, it's been something we've been aware of for a while. It's been reflected back to us because most of our guidelines are in single clinical conditions, and as rightly pointed out, most patients, as they get older, have more than one. So our work programme has been given to us in those single conditions. There's always an element of the evidence being in patients with single conditions, which tends to drive that focus. But we are now looking at how we might do guidance for common multimorbidities, so looking at sort of things that often appear together, hypertension, diabetes, those sorts of common conditions, and looking at how we better map together and present the rest of the guidance. Some of that we will aim to do ourselves as part of the Pathways work programme, but we're also looking to work with external providers of computer decision support systems, for instance, so that what we've said can be mapped into a more interactive access for
Great. Alex and then Robert.
Yeah, I mean, it feels like there's probably some really interesting challenges in all of that for NICE, and particularly given the urgency that was one of the previous questioners was talking about, and the fact that some of these more joined-up approaches are emerging and they're less frequent, perhaps less well-researched. I think there's just a really interesting challenge in terms of how NICE is going to produce guidance and standards which drives towards these emerging areas of practice, because there's always the risk that the standards go where the evidence is, and that actually drives resources into perhaps a slightly better, or definitely a slightly better version of what we already have, but doesn't actually drive those resources into these rather radical new shifts in terms of areas.
I should have also added that we've now got some topics specifically about the sort of general approach to managing people with multi-morbidities, both from a health perspective, but also the management you might expect, say, in a residential home of a complex set of conditions that you often find in the frail elderly. And the QOF, you mentioned the QOF. People probably know that it's going through a change. Some of the numbers of QOF indicators has been reduced, and there will be some further developments that NICE will take on, and we're expecting, for instance, to think about indicators that are more outcome focused. So in the past it's been a lot about process of care, how diabetes care is provided, say, but with a trend for the future to possibly getting more genuine outcome measures that might address some of the things that you raised.
I support quite a few of the changes that have been done. I think it's also important to recognise that, in fact, it's Abraham who's demonstrated this, that actually we spend 20% of our medical resources with people who've only got about 6 months left to live. And what do we do with that 20%? We put them into hospitals, or we give them more and more nasty drugs, when actually what they would really want, if you ever had that question with them, they would want to be supported in their own home and actually able to live out their lives with the best quality that they possibly can. And so I think that if we got to a position, for example, with multidisciplinary team meetings, when the only person who's not in a multidisciplinary team meeting is the person themselves. So how have we got to that position? So those are some. I know it's not everywhere, but it is the practice at the moment is normally that. So we need to engage the person, the citizen, in some of those decisions, and we might get very different answers if they knew what they were contributing to.
Mm-hmm. It's critical for adult social care as well, the whole evidence-based debate, both in terms of viability, quality and affordability. We did a piece of work with public health colleagues when they were part of the Primary Care Trust 2 years ago on our people who use domiciliary care services and their carers. And 80% of the people had one or more of 4 conditions, COPD, CVD, dementia or diabetes. And it was a very simple finding, but quite a staggering finding in terms of the way that we as a local council now need to engineer the public health offer back to the clinical commissioning group. So the evidence base really can translate into very good quality social care in terms of targeting. And I love the phrase compressed morbidity, the idea that you have lots and lots of years of healthy life and then just fall over in the last year. Because what's been said there about the hospital experience is not a good end-of-life care experience. And we need to really think about end-of-life care as an increasingly critical issue.
Great. Well, back to the voting. I'm just going to close the second poll and look at the results to that. We asked what the biggest challenges were that you face locally in the integration of health and social care. The single biggest one which has come out is a combination of all of them, which got nearly 53% of the votes. But looking down at the individual ones, commitment from cross-sector partners and lack of consensus were both at 7%. Finance resource pressures came in at just over 13%, but the biggest single one was actually communication and coordination at just under 20%. And that's interesting. It's often the case that we find that it's the human issues which are the most demanding ones. It's not technical questions, it's not questions around resource, it's actually getting people to work together. And that probably underlines the importance of really powerful leadership around this, doesn't it? I wonder if any of you have got any observations on that second poll.
Absolutely, and a shared vision as well, because I think it's hard to communicate effectively if you're perhaps using the same words and meaning completely different things, which I think we come across quite a lot in that interface between health and social care.
John? There's been a living example for all of us in the last 6 months in the transition of public health into local councils. The cultural issues have been the outstanding challenge. The technical stuff's been hard work, the innovation of contracts, the TUPE-like transfer of staff, the creation of new budgets, the move of buildings, etc. But they're relatively easy compared with the cultural shifts. So public health has got a different perspective on personal responsibility for healthcare than councils have. And individual councillors may have different perspectives on, do we spend public money on helping people stay healthy, or is it their responsibility? So I think culture is critical. And one of the real lessons in the Greenwich experience was the long time we spent on getting staff to articulate the ambitions of the new shared services. So the technical bits can be challenging, but they're relatively easy compared with the softer cultural bits.
I'm not surprised about the all of the above, because the evidence base around any sort of change is that it's multifactored. There's never one thing you can focus on. There's lots of things that you have to address. So that fits. And we talked earlier, didn't we, about the communication and the language. Something that, in respect of what NICE is doing, I'm trying hard to address, because there are phrases that are much beloved of certain sectors. Reablement, for instance, which is well known in the social care sector, not in others. And so it's an approach where we'll use, as far as possible, plain English and reflect those more sector-driven phrases as well, but be clear that we can use plain English and talk to all the audiences.
Language is a really powerful driver for this, isn't it, Robert?
Well, I think the two things that are interesting, I think you could say all of the above, but my view is that one of the big difficulties is how do we actually get these services to be actually working together around the person? And actually, it's some of this communication which everybody says is down to information governance. Everyone says everyone wants to share, but actually when it comes to it, there are various things that seem to get in the way. And whatever level you talk at, apart from the top level who says it isn't a problem, it always comes forward, and we don't know how to solve this simple information sharing. If we were to put a lot of the information and recognise that very little of this information is anybody's but the citizens themselves, and in fact all of the information that's held in each of the organisations is only how they came to give that advice. The information, the tests, the opinion, actually it belongs to the citizen, to the individual. But and it's ridiculous that we can't solve that. I personally don't think we'll solve it by having a care record, a health care record, because I don't think that it's going to be sufficiently broad to be the way that the new citizen, the new person is going to want to have. So their own information would have to be on there, for example. It should be shared with pharmacists, for example. It should be shared with the voluntary sector, for example. And it definitely should be shared with social care. So we've got to move to a different place of doing that. And one of the barriers to this, from my point of view, is on who should resource. Who is the benefits realiser is the word that comes forward. And obviously it can't really be the citizen. So we have to try and take a system-wide approach to this and get into more interoperability, but interoperability around the citizen themselves as being the place, and also getting them to be able to see the information that they want to see, not the information as a deluge of information. So how do they get the intelligent usage of information? And that can apply to everybody, because everybody has got a different need to see the information. It's not all in the same format. And we could then move to some really exciting things around exclusion of minorities, etc., who at the moment get an English, if they get anything, they get an English discharge letter or whatever it might be.
Alex, you wanted to come in.
Yeah, I was just going to I think it's come back to that point around involving providers in trying to develop innovations as well. I think when the discussion is entirely on the Commissioner side, it can get very bogged down in process and it can be slightly theoretical. And I think what people also need are just practical examples of what this looks like. Yeah. So if I can shamelessly plug Shared Lives as an example of what it looks like. And for people not familiar with the Shared Lives model, it involves people from all kinds of backgrounds being approved by their local Shared Lives scheme and then matched with an adult who needs support. So, and then they share family and community life. So typically it's used as a social care intervention, often for people with learning disabilities who will move in with a shared life carer as part of their route to independence or somewhere to belong. But it's an example of what we would describe as this sort of networked, integrated model, because it provides personal care. It's a regulated service, but it does so within the context of an ordinary family home and with somebody who has the freedom, and actually there is the expectation that they treat you as part of the family, that they treat you as much like a friend as they, rather than like a patient or a client. So it kind of mixes those two domains, and it's been really interesting to see some NHS commissioning of that. So there's an NHS trust which has developed a service using that Shared Lives model for people in the acute phase of mental illness. So rather than being on a hospital ward, they're spending a week or two with a specially trained shared life carer and their family. So practical examples like that, I think, are really important in moving things forward and getting out of the theoretical and the systems side. And as you said, there's a danger that structures do what they're good at, which can be the kind of the systems alignment, and we don't actually just get on with things that people can really see in real life.
It's great to hear such a wonderful practical example. And talking of practical examples, it's time to launch the third poll as time moves on. And what we're now looking at is what NICE can do to provide more support to integration. So is it practical guidance on joint working, resources to help commissioners develop integrated services, local support for health and wellbeing boards who are really important in all of this, guidance developed by care groups, Jill was talking about that earlier, or resources for local councillors. Obviously working with local authorities, there's a local political perspective on this. So that's going to run for the next 4 or 5 minutes. In the meantime, If we could just go back to looking at the leadership around this. We touched earlier on the leadership requirement. Who's best placed to deliver that at a local level? Is the Health and Wellbeing Board the area that we should be looking at for leadership across the system? Is it commissioners within CCGs and local authorities? What role do the citizens potentially have as leaders of this change? I'd be interested in any reflections you have about where the leadership might come from in this new way of delivering systems.
I mean, just looking at health and wellbeing boards, constitutionally they are subcommittees of a council at the end of the day. So potentially we have 150 committees of councils running the health and wellbeing system. So that gives them their constitutional legitimacy. Participation then becomes the next big issue, because at the end of the day, these systems won't work on voting rights or that kind of decision. So I think the issue of citizenship really comes into the health and wellbeing context. And I think it is about community leadership, but it's also about resilient communities. We mentioned the word resilient earlier on, and that can apply to communities as well as individuals. How do we build the ability to be self-sustaining and less dependent and overcome challenge? I don't think it'll be health and wellbeing boards on their own. At the end of the day, they will meet 6 times a year. You do not manage complex whole systems by discussing them 6 times a year. So the substructures and the citizen engagements will be a critical part of that. So health and wellbeing boards have a part. They can't be the sole arbiters of the new future.
Thank you. Robert?
Yeah, I mean, I fully agree with that, because I think we've got to look at this leadership thing. Everyone says it's leadership at all levels, so that's the first off thing. I think the Health and Wellbeing Board has got a responsibility to coordinate some of that or be assured that it's being done. And I think from a Kent perspective, we've got to recognise that there's a lot of leadership going on at the local level, i.e. the 7 CCGs that we have, but also the local organisations and the local providers and the wider providers of care, such as the voluntary sector, who've also got their own leaders. And we need to bring them into this fold so that they help us to understand what the Kent Pound could look better at. And the citizen part is absolutely key for me, because I think we have to move to a place that we actually have a social movement that changes this model of care from a medically dominated model of care towards a supported self-care. And I mean by supported self-care that they get the support that they need to feel safe in their own home, so that they say, we want to stay in our own home, they want us to stay in our own home, and we're going to be safe to stay in our own home.
I would agree that health and wellbeing boards should be extremely well placed to be leading some of the change and to be leading local engagement. We also know that NHS England has been engaging at a local level through their Call to Action programme. So there is a bit of a groundswell, isn't there, about trying to understand what people are really looking for, and we need to listen to that. What do people want? I think there is also a role at a national level for organisations like NICE, working with others, to set out how some of that might be achieved, drawing on the evidence base. What are then the models that we think might best work? So not to impose them necessarily, well, not at all, I don't imagine, but to set out the evidence base around models of care that can support that local change.
Great. Well, that seems like a really good point to look at the results from the third poll, which I will now just close. This was around the practical support which NICE could develop. And just looking down through them, the one which is most popular is practical guidance on joint working, which may be just what you've just been describing, Jill, at just under 44%. At 33% were resources to help commissioners develop integrated services. 12% guidance grouped by care groups. Support to local health and wellbeing boards at 8.4%, and the last at just under 4% was resources for local councillors, which interestingly Victoria Hughes has sent in a question saying, is that really NICE's role to provide resources for local councillors anyway? So I wonder if you've got any observations on what NICE's role could be to help here, Jill.
Certainly providing guidance is what we do as bread and butter, so guidance on joint working is certainly something that we need to take seriously, having had the majority of people giving that as their favoured response. Most of what I suspect we're doing at the moment is producing guidance that relates to a lot of different organisations, and so somehow then facilitating that joint working to all take forward and implement the guidance would be key. And perhaps we need to think about how how the field team that you're responsible for, Steve, how that can best engage at a local level to support that joint working. We do provide some resources for commissioners at the moment, and as we do more and more in the way of integrated guidance that looks across sectors, there will be an opportunity for us to provide resources for commissioners that underpin that. So pleased to have the feedback and take it away.
Did you have an observation, Robert?
I did. What they shouldn't do, and that is they shouldn't just barrier it so that social outcomes are done in isolation and create yet another barrier in terms of the different totality of resources that people need. And I'm sure they won't. So I'm quite pleased that NICE is getting into this area around social outcomes. I think also what they can do is to recognise that the medical outcomes that I mentioned earlier actually need to change as people get towards further down the journey, and whether that's towards the end of life or further or with multiple conditions, then I think we need to understand that the ways that the mechanisms are set up at the moment are very barriered and very medical, and that's great. But it can also be very detrimental. So as they converge, we need to find new guidelines to understand that the outcomes are about exactly the things like people feeling supported at home and feeling that they're actually getting the right care, so that we move away from this Victorian model of hospitals being the hospitality units, and that outpatients are the place where older people should be spending their life going around the county visiting all of the time. How do we take all of that together?
What my parents do.
Well, absolutely. But actually, we were talking earlier that we said, well, it's quite surprising that sometimes people the organisations don't talk to each other. Well, I'm afraid that's how the system is at the moment, and that's the norm. It's not always like that. But we need to move to a very different way of building the care around the citizen. And if NICE can help us in that, and if they can help us to change some of the tariffs to do that, then it would help us and promote integration, whereas the barriered, siloed way we work at the moment, I'm afraid, actually tends to stop integration.
We've had a point in from Mike Leaf, actually, around how we identify and build on community assets rather than focusing on services, and I think that's exactly the point we're getting at here. Alex, you wanted to come in.
Yeah, I was just going to observe that NICE, moving into social care and thinking through integration is obviously moving its range of products into some pretty different commissioning environments, or certainly different purchasing environments. So there was this question about whether resources for local councillors are sort of NICE's business or not. But I think the idea of what a quality standard or a piece of guidance is there to do needs rethinking, and it's particularly in the context of social care purchasing being increasingly towards personal budgets and direct payments. So it's individuals purchasing. Does there need to be information for citizens about how they make their own decisions? And that links to that earlier point about leadership. Sometimes in social care there's been some quite glib talk, I think, about personal budgets, putting people in charge. And actually what we've discovered really is that personal budgets, for most people, help people become consumers, and I think it's better if they are informed consumers than uninformed consumers. But actually, if you really want citizens to be able to act as leaders, they have to be able to get together in at least small groups and exercise that purchasing power collectively. And then you start to find citizens moving into that commissioning space. And is there a role for NICE in the future to help people do that?
It's interesting that Kent has for quite a long time now had the Kent card to actually allow people to purchase their own social care, and that's becoming increasingly the default. And actually it means that people are using it in a much better way. Of course it feels difficult as a doctor to let go of the control, but actually why shouldn't the person have a view about how they should be looked after and how they should be supported, rather than necessarily having to follow what the medical model of care. So I think we could learn from the Kent card that actually giving people the facility to make their own decisions is actually a good thing, not a bad thing, and actually they can make a better use of it than we could potentially as some of the professionals, providing they get access to the right professional advice and support at the times at which they need it, so that they don't feel unsupported and aren't left to make unreasonable sort of decisions.
And with the advent of personal health budgets, of course, this is going to become really something that health can no longer ignore. The legislation is in place there to allow people to do that.
Yeah. The idea of the asset-based approach to individuals and communities actually challenges one of the fault lines in the Care Bill approach. Because because we have quite a tension between the universal offer, the ambition of prevention and rehabilitation, against the dependency-based model characterised by universal eligibility criterion or the portability of social care assessments. There's that tension between the universal offer and prevention and the asset-based approach of criteria. But in terms of individual budgets, whether it's health budgets or not, it's a different model. If you're knocked over by a car, you'd want to go to A&E, not give them £10,000. So that's interesting. But I think commissioning will become about arranging options for people rather than procuring services. And I think it's very different between health and social care in those two worlds, because potentially a £100 million commissioning budget is actually devolved to 6,000 people who spend it as they wish. So there's, around the care bill, around health budgets, around personalisation, there were some real tensions emerging between the traditional dependency model and the forward-thinking prevention model.
Great, thank you. We're getting into the last couple of minutes of the webinar, and there's one point which I want to pick up, which Sakthi Karanati has emailed in, around workforce transformation implications. We've not touched really on the workforce and how that might need to change. And I wonder if anybody's got some very quick observations around what we need to do to ensure that our workforce is equipped to work in this new way. Robert?
Well, I think it's got to change. I just don't think it's fit for purpose as we move on into these challenging times. We don't want more of the same. So let's have more of something different. I think that means that it's going to be uncomfortable for some people who've got to learn to work in different ways and provide services in different ways. But I fundamentally think that the workforce question is absolutely correct and is one that we need to stand up and try and face. And there will be some real challenges with that, particularly with an older workforce potentially in health and less so in social care. But we've got to address that issue.
Alex, very briefly.
So very briefly, I'd like to see skills like listening, empowerment, community engagement, community development as a core part of pretty much every public servant's skill set.
Jill?
Well, the challenges we're facing are an ageing population with multiple morbidities, and we're recognising that has an impact on staffing in hospitals, and we need to predict that better, I think, than we have in the past. We're now playing catch-up, and so part of what we're doing within NICE's work will need to look at the future recommendations and to plan the workforce accordingly and to support those that are involved in that.
Fabulous. Well, that seems to be a really good point to draw things to a conclusion. We've run out of time. We've had a really good conversation. I'd like to thank the panel in the studio for a really invigorating conversation around some of the challenges, opportunities and potential solutions to the Integration Transformation Fund and how we can use it more effectively. I'd like to thank those of you at home and in the office who've been tweeting in, sending in questions. We didn't manage to get through all of them, but I hope that we managed to get a fair smattering. And I'd like to remind you about the NICE annual conference, which is taking place in Birmingham on the 13th and 14th of May next year. We hope to see you there. Thanks very much indeed, and goodbye.